Good day, and we're still busy with the obstetric emergencies, part 1. And in this lesson, we're going to deal with cord prolapse. Now, cord prolapse emergency says emergency is something that we have to react very urgently on to save, in this case, the life of the baby. So, we look at two kinds of cord problems, if I can call it like that. The first of all is the cord presentation, and the second one is the cord prolapse. Now, in the case of a cord presentation, it's usually in the case where the membranes are still intact, that we can feel that there's a part of the a cord next to the fetal head. When we do our vaginal examination, we can feel the cord just in front of the presenting part. While in the cord prolapse, the membranes have ruptured and the part of the cord is now outside of the cervix, and we can get different degrees of cord prolapse, where the cord is either still in the vagina or the cord can be outside of the vagina. Now, as I've said, in the case of a cord presentation, it's usually the membranes are still intact, and the way that we manage this is to do a cesarean section the moment that we have done our vaginal examination and have diagnosed the cord presentation. And usually one can feel that the cord is still pulsating, which is an indication for us that the fetus is still alive. Now, in the case of the cord prolapse, how do we diagnose it? As I've said, we get different degrees of cord prolapse. It's when the cord is being felt here, like in this case, just inside the cervix, or we might feel it in the vagina, or we might see that there's a loop of cord that's visible in the vulva outside of the body. Now, fetal hypoxia occurs because of two main reasons, and that's what makes this an emergency. The first one is occlusion. Here, between the presenting part and the pelvis, the cord might be, there's a lot of pressure here on the cord, and that might cause that the cord is totally occluded, that there's no blood circulation going from the placenta to the fetus. Or the other thing that happens is when specifically in the case of when the umbilical cord is outside the body and it's been exposed to cold air, all these blood vessels in the umbilical cord might go into a spasm. And that also makes then that there's not enough blood circulation from the placenta to the fetus. Now, possible causes of cord prolapse. One can summarize it by saying it's all causes or all conditions where the presenting part does not fit properly on the cervix. So where the application of the presenting part is not well on the cervix. So there's literally place for when the membranes rupture for the cord to come past the presenting part, literally swim out past the presenting part and come lie in the vagina or in the vulva. And this is usually in the case of abnormal fetal presentations, like for example what we said in the breech presentation is that the breech doesn't fit as well on the cervix as the vertex, because the vertex is a hard bony part, while the breech is usually a soft a part with openings. It's not hard and round, and it doesn't fit well on the cervix, which cause that the cord can prolapse. Also in the case of prematurity, because then the presenting part is also small, it doesn't really fit well on the cervix, and there's also space for the cord to come past. Multiple pregnancies, the reason why in multiple pregnancies we might get cord prolapse is also, like in the case of abnormal fetal presentations, we often get abnormal fetal presentations in the case of multiple pregnancies. Polyhydramnios, where we get a more than normal amount of liquor, then when the membranes rupture, the fluid literally comes out with a rush, with a gush out, and the cord can come and swim literally out with the lots of fluid that's coming out. And then in the case of a cephalopelvic disproportion, we get that because the head can't engage well into the pelvis, we also get that the application of the presenting part is not well on the cervix. The head usually sits high, and that is one of the biggest causes of cord prolapse. And then iatrogenic causes is where you have done something that caused the cord to prolapse, and one of the biggest problems here is where an amniotomy is being done, where the membranes have been ruptured artificially with a head that's still high, and that makes that there's lots of space for the cord to come out, to swim out literally with a membrane. Now we come to the management of the cord prolapse. What do we do if the cord has prolapse? Now this depends on a few very important factors. The first of all is the fetal condition. Is the fetus still alive or not? If the fetus is still alive, then obviously we must act as quickly as possible to save the life of the fetus, because we've said that our big problem here is fetal hypoxia because of the pressure on the umbilical cord, so we have to act very fast. The fetal maturity is very important. If the fetus is viable, then obviously again we have to do our best to get this baby out as quickly as possible. If the fetus is not viable, then for obvious reasons we don't need to act that fast, because the prognosis of the fetus is then in any case very small. The dilatation of the cervix, if the cervix is fully dilated, we can expedite the delivery by a means of a instrumental delivery and get the baby out as quickly as possible. But if the cervix is not fully dilated, obviously the patient will have to go for a cesarean section, and in the meanwhile, which we will come to just now, is to make sure that there is as much as possible oxygen going from the placenta to the fetus. Then when there are associated abnormalities, for example, a CPD or a placenta previa, that makes our situation even more complicated, and that also influences the prognosis of the fetus. So this also will make it important to do a cesarean section as quickly as possible. And then also the fetal presentation, if it's a normal vertex presentation or a breech presentation, then and the cervix is fully dilated, then obviously labor can be expedited and normal delivery can happen as quickly as possible. But when the fetus is in an abnormal presentation, then obviously we need to do a cesarean section need to be done as quickly as possible. So a prolapse cord can then be ignored in the following instances: where there's an absence of fetal heartbeat. As I've said, when the fetus is already dead, there's obviously no reason for a lot of haste and hurry, because then the mother can dilate normally, the cervix can dilate normally, and a normal delivery can happen. Or the same in the case of an abnormal fetus, for example, an encephalus or a gross abnormality, where the prognosis of the fetus is in any way not good. Or in the case of a markedly premature baby, and specifically before viability, 26 or 24 weeks, where the prognosis of the fetus again is very small. So first of all, because of all the factors that we have identified in the previous slide, we need to do a vaginal examination as quickly as possible, and to determine whether the cord is still pulsating, which will determine then for us whether the fetus is still alive or not. And then while we are doing the vaginal examination, obviously, we can also determine the cervical dilatation, whether the patient is fully dilated or not. And then if the patient is not fully dilated, then it's very important not to remove our fingers, but continue to push the presenting part off the cord, because as we've said, that is the biggest cause of hypoxia, because the presenting part presses on the cord and occluded the cord. So as I've said now many times, our management depends on the stage of labor. So if the cervix is not fully dilated and the fetus is alive, what are we doing now? Now, what I'm saying here at the bottom of the slide is actually the most important part of the slide. Our main aim is to decrease the pressure of the presenting part on the umbilical cord while we wait for the patient to go to for a cesarean section. So first of all is to immediately arrange for a cesarean section, and if the patient is not in a hospital or in a clinic, is to transfer the patient to a hospital where a cesarean section can be done as quickly as possible. Then the time is very important, because we've said that hypoxia is our big problem because there's pressure on the cord, and we know that the longer this hypoxia is, the bigger the possibility of brain damage in the case of the fetus. So we call for help as this is an emergency, and then if there was an oxytocin infusion on, we stop it as quickly as possible, so that the contractions don't want the contractions to become stronger, because the stronger the contractions are, the more pressure there is of the presenting part on the cord. Explain to the woman to stop pushing, as specifically in the women who are bearing down prematurely, because this also obviously will make that there's more pressure from the presenting part on the cord. Then very, very, very important priority is, which we very often ignore, is that we have to keep the woman informed all the time of what's happening with her, because she knows that there's a rush, that everybody's excited, that something is wrong with the baby, and we need to inform her of what's going on. Now, if the cord is outside of the vagina, it should be gently replaced back into the vagina, because as we've said, the big problem with the cord outside the vagina is when it comes into contact with a colder, the environmental air is always colder than body temperature. So when the cord comes into contact with the external air or outside air, we get that there's vasospasm of all the veins and arteries in the cord, that also contributes to hypoxia to the fetus. So first of all, we put the cord back into the vagina, but we're not covering it with a towel outside the body, because the more we fiddle with the cord, we also create vasospasm. So there should be the minimum handling of the loops of cord, and to prevent this vasospasm. If the presenting part, when we have done our vaginal examination, has felt that the presenting part is pushing really hard, compressing hard on the cord, we need to lift the presenting part off the cord, as we've said, with our fingers. And we also need to position the woman, which we will come to just now, to help to relieve the pressure on the presenting part by helping it with gravity. Like, for example, we can put the patient in a knee chest position, Trendelenburg position, where gravity will take the presenting part a little bit off the cord, and this is also releasing the pressure on the cord. Here we can just put the woman in a lateral position and put something under her buttocks, that the buttocks are higher than the rest of her body, which has a similar gravity effect. Or in a Trendelenburg position where we lift the foot end of the bed. What we can also do to try and relieve and release the pressure of the presenting part on the umbilical cord is to put a Foley's catheter in the bladder and to connect it with an intravenous infusion and to fill the bladder with 500 to 750 milliliters of saline. And then we all obviously have to clamp the catheter so that this fluid can stay inside the bladder. And what it literally does is, as you can see on this diagram, because the full bladder sits here right in front of the above the symphysis pubis, it will push the presenting part up a little bit, and that will also help to release the pressure on the cord. The other things that we need to do is when the cervix is not fully dilated is to start an IV infusion with Ringer's lactate like we always do when something is abnormal. And then we can also in the IV infusion start giving tocolysis, because what if we can stop the contractions or make the contractions a little bit lighter and not so strong, it also helps to release the pressure of the presenting part on the cord. So we can use 20 milligrams of short-acting nifedipine or Adalat, or we can give salbutamol. Now, I think in many of the salbutamol is according to the maternity guidelines that has been compiled by the Department of Health, but in many of the private hospitals, that every hospital might have, or labor ward might have their own guidelines on which kind of tocolysis can be used in the case of cord prolapse. Then very importantly, we need to continuously monitor the fetal heart so that we can see whether all our efforts are working and the fetus is still in a good condition. And then a cesarean section, as I've said, as quickly as possible. But then what is very important is before the cesarean section is being started to make sure that the fetus is still alive. Because obviously, as I've said previously, if the fetus is not alive anymore, labor can take its normal progress and the baby can be born normally. And then very important is to expect and prepare for fetal resuscitation. There's a very high likelihood that this fetus will be compromised to a certain extent, and the APGAR of the fetus might be lower when it's been born. So we have to make sure that all our resuscitation equipment is ready and in a working order, and preferably that a pediatrician should be present at the birth of the baby. Now, if the patient is in the second stage of labor and we now have a cord prolapse, as we've said, very important is just to get the baby out as soon as possible. So we can expedite the delivery with an episiotomy and a vacuum extraction or a forceps delivery. Or if the baby is in a breech presentation, we do a normal breech delivery and get the baby out as soon as possible. And again, we expect, or we can expect, that the baby will need resuscitation, so we need to make preparations for that as well. If the cord is not pulsating, like I've said now many times, the fetus is not alive anymore, and that needs to be confirmed. It will be confirmed with a CTG or a sonar, and then we know that that labor can take its normal progress. The patient can deliver normally, and the baby can be born in a normal vaginal delivery, which is by far the safest. And also not only when the fetus is not alive, but also in a very premature pre-viable baby, and also in the case of a grossly abnormal baby. And again, we came to the end of the lesson, and please complete your quiz, and then you can go to the second lesson. And again, I hope that you've learned something.